Our next case is a patient who has chief complaint of rash for 3 days. You have a 7-year-old boy who's brought to the office because of a 3-day history of a rash. His mother reports that he has had fever and malaise for 5 days. He attends daycare with several other children who have a similar rash. Now in the office, his temperature is 101.3 Fahrenheit. On physical exam, he has a diffuse rash, more on the face and the trunk. There is a wide range of lesions from 5 to 10 millimeters in diameter on an erythematous base. Some are macular-papular, some are vesicular, and a few happen to be crusted. There are no oral or mucosal lesions. If we think about our differential diagnosis, whenever you hear about a rash that has papules, vesicles, and crust, and they're in different stages, you must consider top on your list chickenpox or varicella zoster. Other things that can be confused or mimic chickenpox might be Staphylococcus impetigo, folliculitis, contact dermatitis, disseminated herpes simplex, Coxsackie virus infection, and insect bites. So the first thing that you want to do as far as your diagnostic plan is to get a good history and do a good physical examination. Because in your differential diagnosis, many of the things that I mentioned are really diagnosed clinically. There's not much of a workup that's needed. You look at it and by observation, you know what the patient has. So in this particular case, no laboratory tests are necessary. Because of the appearance of these lesions, we know that this particular patient has chickenpox. Remember that the lesions for chickenpox start on the face and trunk and progress to the extremities. And usually the appearance they'll be coming for about 3 to 4 days. The number of lesions that a patient will get will be variable. However, for each patient in a household that acquires chickenpox, the more lesions they get. So if you have 3 siblings, the first sibling will have less lesions than the third sibling who acquired the chickenpox. Remember that chickenpox in adults is worse than to get it as a child, and that in a normal host, the most common complication or sequela would be a problem with your skin. You might get an impetiginous lesion from scratching. However, adults, in addition to the skin problem, may develop pneumonia. So what would your treatment plan be for somebody who had chickenpox? First of all, it would be supportive treatment. You'd want to make sure that you gave good skin care and daily washings to prevent any bacterial infection or superinfection. You want to make sure that if a person was immunocompromised, so for instance, a question on your exam could be that the patient has leukemia and is on chemotherapy, and she was just exposed to her cousin who has chickenpox. And perhaps she didn't receive the varicella vaccine. Because we said the varicella vaccine could be given anytime after the age of 12 months. So in this particular case, they would ask you what the next step is for treatment. And the next step would be that for this particular young lady, she would need the varicella zoster immune globulin. This would also be given to any newborns who were exposed to maternal varicella. Okay? That's a key point, and that could also be a question on your exam. If I have a newborn that's 2 weeks old and they develop varicella, they are at no greater risk than the rest of the population for that outcome. However, if I am a newborn and my mother has varicella 5 days prior to delivery, or 2 days after delivery, then I'm at risk for varicella, getting it, and also for death. Because the incubation period for varicella is going to be about 2 to 3 weeks, all right? 11 to 21 days. If my mother now has chickenpox, I was exposed to that in utero. And so if I know that as a physician or a clinician, then what I need to do is make sure that this patient gets VZIG, which is varicella zoster immune globulin. If the patient does develop chickenpox, even with that passive prophylaxis, then I'm going to have to make sure that I use acyclovir. What else do I need to remember? You need to remember that acyclovir would only be recommended in that particular case. It is not recommended by the American Academy of Pediatrics in an otherwise healthy child. Okay? So it only would be in the immunocompromised child or in an infant whose mother now has chickenpox and it was 4 days prior to delivery or 2 days after delivery that the mother developed the chickenpox. If everybody in the household's developing it 3 and 4 weeks later, the infant is at no greater risk than the general population. There's no special lumbar punctures or anything that we have to do, for that particular infant. Now, the question again would come up, when can I tell the patient to go back to school? The patient may return to school and or daycare when every lesion is dried and crusted. So if you have any vesicle, even one vesicle, you're still contagious. Therefore, all lesions have to be crusted. Other things that you need to be thinking about here is the final diagnosis is chickenpox. And some of the things that you should consider when taking your examination or treating people with chickenpox is that it's transmitted via the respiratory route. So if you have somebody who has chickenpox in this room, we're exposed to it if we're not immune. I don't have to touch a lesion in order to become exposed to chickenpox. Remember also that the rash can appear on any mucosal surface. So in your throat, on your tongue, on your genitalia. The rash can appear in any of those mucosal surfaces. And crops of lesions in various stages is the way that they might describe it. Again, clinical diagnosis, no lab, your treatment is symptomatic, and your acyclovir is only used, and your varicella zoster immune globulin in high-risk cases. Now, we said that Staph aureus impetigo might mimic chickenpox. Why? Because, again, it starts as a papule, it turns into a blister or a vesicle, it pops and turns into a crust. However, the bullous impetigo can occur on your face, on your extremity, on your trunk, and there's usually just a few lesions. It's not multitude of crops that just keep coming out like the chickenpox. Remember, we talked this morning that the patient could have a topical or systemic antibiotic therapy depending on the extensiveness of the impetigo. Remember that children with impetigo should be excluded from child care settings until 24 hours after appropriate therapy is initiated. What about folliculitis? Folliculitis is a superficial infection of a hair follicle, and it's usually caused by Staph aureus. What you're going to see are dome-shaped pustules on an erythematous base around the hair follicle. Can be located where you have hair. Usually it's on the scalp, in the genitalia, or it could be on the extremities. Remember that the lesions will heal without any scarring, and poor hygiene contributes to this as far as other contributors, occlusive clothing, could also contribute to a folliculitis. The treatment would be just topical cleansers, topical antibiotics. Again, if you have a more severe folliculitis, you would need to give penicillinase-resistant systemic antibiotics. What about herpes simplex? Whenever I hear about vesicles on a red erythematous base, immediately what comes into my mind is herpes. However, what you need to be thinking about is that these herpes lesions may burn. Where the varicella lesions are pruritic, the herpes lesions may burn. Remember that children who are immunocompromised may develop these, and you could have a generalized eruption over a period of about 2 to 3 weeks. If I wanted to make a definitive diagnosis, I could order a Zank stain and look for multinuclear giant cells. My treatment for this should be acyclovir. Remember that covering of active lesions is usually sufficient to let the child go back to school or to child care. What about hand, foot, and mouth disease? Hand, foot, and mouth disease is caused by Coxsackie virus infection, and it's a Coxsackie virus A16. What you're going to see are a skin rash plus lesions in the mouth. Again, ulcerative lesions located in the oropharynx. You're going to have lesions on the hands, the feet, and the buttocks. It's a clinical diagnosis. The patient who has the Coxsackie virus, the treatment would be supportive. The main problem is that their mouth hurts because they have ulcers in the mouth. Therefore, you want to make sure that they have good hydration. You want to make sure that you also tell the mom that sometimes by offering cold foods like popsicles or ice cream, it may numb the mouth a little and help the child to take the fluids. Other things that you want to be thinking about are that you can give Tylenol or to control the pain. Some people would suggest that you might be able to have a mixture of Benadryl and Maalox to coat the mouth prior to breakfast, lunch, dinner, and at bedtime. You want to exclude these children from school or daycare only if they're refusing to drink. All right? Because usually the school and daycare exclusion typically is not necessary. However, if their disease is so severe that I have to put them in the hospital, then they would be excluded from school. But otherwise, it's not necessary. It's just good, careful hand washing and personal hygiene would be encouraged. If the patient, this is just an aside, but if the patient had just lesions in the posterior part of the oropharynx, and they were ulcerative lesions, that is also usually caused by Coxsackie virus, but you're missing the hands and the feet. They call that disease herp angina. And the reason I bring it up is that sometimes in your examination or in your office, you'll have to tell the mother or you'll have to tell the examiner what's causing those ulcerative lesions in the pharynx. And you should know that that is still Coxsackie, all right? The fact that the name is herp angina would sometimes confuse students to make them think that it's caused by herpes simplex, but it's Coxsackie. So herpes gingivostomatitis is more forward, involving the tongue and the gums and the lips. So that's how you can pretty much differentiate herp angina caused by Coxsackie from herpetic stomatitis. What other things can mimic chickenpox? Flea bites, insect bites, mosquitoes. Okay, and one of the other reasons that they can mimic is oftentimes they itch. If the child is scratching, then the child is disrupting the layer of the skin and sometimes giving a point of entry for organisms to form an impetiginous lesion. So again, this is one of those reasons. Remember that as far as insect bites, the treatment would be oral antihistamines to stop the itch, cool compresses, and lotions. You should always advocate for your patients to use insect repellents, which could alleviate the problem totally. All right, our next case is going to be chief complaint of fever and difficulty breathing. You have a 2-month-old boy who's brought to the office during the winter with a 2-day history of fever of 101 degrees Fahrenheit and difficulty breathing. His mother reports that he has also had a poor appetite and he has clear nasal discharge. His 4-year-old sibling has a cold. The patient is with an unremarkable birth history. He has no significant past medical history. He appears to be active but in mild respiratory distress. His pulse is 160, which is about within normal limits for a 2-month-old. His respiratory rate is 60 per minute, which is a little rapid. That's tachypnea. And his temperature is 98.6. Say febrile. We continue the history, and we find that his neck is supple. He has bilateral expiratory wheezing, subcostal retractions, a normal heart rate, no murmurs, a benign abdomen, no cyanosis, and good perfusion in all extremities. He's not dehydrated. His skin is clear. Things that I need to be thinking about as far as the differential diagnosis would be, does this patient who's 2-month-old, who presents with afebrile and rapid respirations, have a chlamydia pneumonia? We talked about that this morning, that the patient could present having a history of eye discharge that could resolve. The patient could colonize the nasopharynx, and by 4 to 6 weeks, the patient could develop what we call chlamydia pneumonia. The other thing is does the patient have a bacterial pneumonia? If the patient has some respiratory distress. We also mentioned earlier that with pneumonia, the triad usually is fever, tachypnea, and cough. In this particular case, the patient has no fever. Other things that could be considered in the differential diagnosis would be asthma. However, the patient does not have any history of wheezing, and we mentioned earlier that the patient, even if they did have some wheezing, would not get a diagnosis of asthma at the age of 2 months. Remember, we said we don't like to really diagnose asthma until the patient is 2 years of age. So we mentioned some things this morning when we said all that wheezes is an asthma. And some of those things were pneumonia, gastroesophageal reflux. We mentioned some kind of anatomical problem. We mentioned that the patient could have congestive heart failure. And now I'd like to suggest to you that the patient could also have bronchiolitis. All right? Other things, a foreign body could cause wheezing. Other things on your differential diagnosis list would be the respiratory syncytial virus, which is bronchiolitis. So your initial plan for this particular patient is, if you could only do one thing, it would be the chest x-ray. And the reason you would do the chest x-ray is that the patient has respiratory distress, and it's going to help you to decide if the patient has pneumonia. The second thing you're going to do is a CBC. It's going to help you to decide if the patient has a bacterial infection or if the patient has a viral infection. We're going to look at the results, and on the radiograph, you see that the patient has hyperexpansion with air trapping. the patient has peribronchial thickening and an interstitial pneumonia. The white count shows that the patient has a 10,000 white count with a shift to the left. However, the fact that this patient has peribronchial thickening or peribronchial cuffing, air trapping, hyperexpansion, makes you think that this patient has bronchiolitis. The patient could have developed an RSV pneumonia. Interstitial pneumonia makes you think that it's viral. Now you're going to say, well, how do you explain that the patient has a left shift? Doesn't a left shift usually indicate that the patient has a bacteria? In bronchiolitis, the shift can go either way. It's equivocal. So it's not going to help you much. They're going to put a left shift, perhaps on your exam, so that you don't know the answer right off the bat. That you have to think about it, or that you know that piece of information. Remember that bronchiolitis is a clinical diagnosis. It's oftentimes seen in the winter. Once it starts, we get an epidemic or a run on it. Remember that when infiltrates are absent on X-ray, there's little likelihood that there's a bacterial component. Now, with chlamydia, we talked about that earlier, you might have had more of a history that the patient had an eye discharge, or that the patient was born at home, or that the mother had no prenatal care. Other things that we want to be thinking about would be, could you do any other further diagnostic plan? It depends. If you're going to admit the patient to the hospital, you want to do a nasopharyngeal swab. The reason that you want to do the nasopharyngeal swab is so that you can cohort the patients, because you would never put a patient who has RSV in a room who had chronic lung disease or with a patient who had heart disease. All right? The other thing is that you might send a nasopharyngeal swab if you were thinking the patient had chlamydia for chlamydia. In this particular case, the nasopharyngeal swab was positive for respiratory syncytial virus. As I said, it's not necessary to do in your office because it's a clinical diagnosis. The treatment plan is symptomatic. What can we try? Well, if it's a component of hyperaeration and if you have some mild wheezing or some rales, you might try to use a bronchodilator. If the patient responds, you can continue to use this. Other things that you would do, especially in this particular patient, because of the age. This patient is less than 3 months of age. The patient has bronchiolitis. This is a high-risk patient, so this patient gets admitted to the hospital. All right? Why? Because you know that bronchiolitis in these small infants can go on to apnea or even present as apnea. So you want to make sure that you keep a good eye on these patients. So our diagnosis is confirmed by the nasopharyngeal swab, and it's the respiratory syncytial virus, also known as bronchiolitis. If we do our case review, looking at the differential diagnosis, we know that bronchiolitis is really an inflammatory obstruction of the small airways, and that RSV, or respiratory syncytial virus, is the leading cause of bronchiolitis. However, it can also be caused by parainfluenza, mycoplasma, adenovirus. Patient usually presents with a history of having an upper respiratory infection, some runny nose, and sneezing. Again, to point out, infants may present with apnea. Physical exam will vary with intercostal, subcostal retractions possibly being present. They may have some wheezing, some rales, some tachypnea. and your virus can be detected with the nasopharyngeal secretions. Remember that your treatment will depend on the severity. If the patient is not responding to the bronchodilators, you might just try using humidified air. How do you do that? You just take some normal saline, put it into a nebulizer, and have the mist go at the face. If this is a patient who has a mild bronchiolitis, they would be able to go home if they were older. Say the patient was 10 months old and he came in and had bronchiolitis. And if he was happy and if he was drinking and his respiratory rate was less than 60 and the parents were comfortable and they had cool mist at their house, or if they had a shower that they could use to make some vapor, or if the patient was responding to albuterol or the bronchodilator, you could feel comfortable to send that patient home with follow-up. However, we have some patients that are at high risk with bronchiolitis, immunocompromised patients, patients with chronic lung disease, patients with heart disease, patients who have neuromuscular weakness, immunodeficient patients. These patients who have bronchiolitis should be considered for treatment with an antiviral called ribavirin. These patients would be admitted to the hospital for observation. Again, if you have patients who are with congenital heart disease, there are other things that can be used for this, such as monoclonal antibody. But with the congenital heart disease patient, they should never receive these because of complications that could include death. So people might say, well, how about if I use the monoclonal antibody, the palivizumab, to RSV? And this has been used in infants less than 2 years of age who have prematurity or chronic lung disease, but you're not going to use it in a patient who has heart disease. I would say that for testing purposes, you need to say to yourself, what do I need to know as a generalist taking care of a patient with bronchiolitis? You need to know that there's a variety of patients that can present, from mild to severe. You need to know that the small infant, the newborn, can present with apnea. You need to be careful with those patients and know that they would most likely benefit from being admitted. You need to know that the mild happy wheezer who has bronchiolitis can be treated with mist, normal saline, vapor. You need to know that you could try bronchodilators, such as albuterol. And you need to know that you're not going to go to the antivirals or to the monoclonal antibodies unless you have severe disease or high risk factor, such as the person who has the chronic lung disease. If you have heart disease, you can be treated with ribavirin. But if you have heart disease, you cannot be treated with the monoclonal antibody. And that would be how to sum that up, or how your approach should be. What about chlamydia pneumonia? Because we had a lot of thoughts when we first started this that this might be some type of pneumonia. Well, remember that the agent for chlamydia pneumonia is chlamydia trachomatis. It's not chlamydia pneumoniae. That's always a test question. Okay, you're treating chlamydia trachomatis. Why? Because the patient is picking this disease or entity up in the birth canal. Okay, it's from an STD. What else is significant about this chlamydia trachomatis pneumonia? The patient has something called staccato cough. Okay, staccato, if you played a piano, would be when you're hitting the key note over and over, quick, 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 quick. All right? And so what this is paroxysms of cough, cough breath, cough breath, cough breath, cough breath, cough breath. Almost where the mother is saying, my baby's choking. My baby can't catch its breath. And there's only 2 things that can give you staccato cough. One is chlamydia pneumonia. The other is pertussis. you'll be able to differentiate because the pertussis baby is usually more ill. Patient usually has a high white count, 30,000, with a predominance of lymphs. The patient may have cough, breath, whooping cough. You don't have to have the whoop to have the whooping cough. What else do you need to be thinking about? How would you see staccato cough right away, it should jump out at you. It has to be pertussis or it has to be chlamydia. Chlamydia, the patient is usually afebrile. Your patient here is afebrile. Okay? Afebrile, staccato cough. But if you've got a white count, the white count is usually normal or low. The white count is not elevated, like pertussis. If you had to think about a predominance, the predominance would be in the differential eosinophilia. Many of you already know the mnemonic for eosinophilia that's seen in the blood, and you can think about it as the letters N, triple A, double C, P. So that's NAAACCP. Well, what does that mean? That means if I was thinking about who has eosinophilia in their blood, it would be people with neoplasms or cancers. People who have Addison's disease or asthma or allergies. People who have chlamydia pneumonia. People who have collagen vascular diseases. Or people who have parasites. So they're not going to tell you the eosinophilia is elevated, but you would have a white count that's normal, and you'd look at the result, and you might see that the patient has 10 EOs, which is kind of unusual, or 16 EOs. The chest x-ray for chlamydia trachomatis would just show some hyperinflation. So once you're convinced that you have that diagnosis, how you would treat would be with orally administered erythromycin. Now, this morning we talked about the triad for pneumonia. Again, I'll repeat myself. Fever, cough, and tachypnea is bacterial pneumonia until proven otherwise. The other things that we've already discussed were the agents from birth to 2 months that this particular infant might have, the group B strep, the E. coli, the listeria, if we were heading down that pathway. Remember, we said this morning that they would get a complete septic workup, including the lumbar puncture, and you would admit and treat these patients with antibiotics intravenously, and we've discussed that at length earlier. We mentioned asthma, but we know that this patient can't have asthma because it's 2 months old. Remember that asthma is reversible and that it affects both small and large airways. And this will bring us to our next chief complaint of rash. You have a 6-year-old boy who has not been feeling well for the last week. He had a low-grade temperature, joint pains, and abdominal pain with occasional vomiting. His mother became more concerned this morning when she noticed that he had a rash on the backs of his legs. He appears tired, but does not seem to be in acute distress. His vital signs are low-grade fever of 100.6. His pulse is 100 per minute, which is normal for this age group. His respiratory rate is 20, and his blood pressure is 100/70. If we look at his physical exam, what we find is that his eyes are anacteric, his tympanic membranes are normal. He has a throat that's pink, but there's no lesions or exudates, and his neck is supple without any adenopathy. We listen to his lungs and his heart, and they're within normal limits. Now we go to his abdomen, and we find that it's soft with some active bowel sounds, but this boy with a rash has an acute, mild, diffuse tenderness. And there is really no guarding, no rigidity or rebound. The extremities are without cyanosis, clubbing, or edema. The patient also has well-defined hyperemic macules that are scattered over the backs of the legs and the buttocks, with a rare lesion on the back of the arms. Some are raised and palpable, and none blanch with pressure. So this person is having palpable purpura that extends from the buttocks to the lower extremities. The patient presents with a diffuse abdominal pain. Putting all that together as you read, you should be thinking that this patient has Henoch-Schönlein purpura. So we're going to continue to see if in our workup and if in our management we're correct. He's currently afebrile. There's no other problems noted on physical examination. So Henoch-Schönlein purpura is at the top of our list. Rocky Mountain spotted fever can also start as a rash on your ankles. You need to be thinking of another rash that can start on the ankles and spread up, and that would be meningococcemia. So you have 3 in your differential diagnosis that start on the ankles and cause purpura or petechiae on the extremities. What else do you need to be thinking about? Well, maybe this patient has a Kawasaki disease. Does this patient have a systemic juvenile rheumatoid arthritis? So in your initial diagnostic plan, because you know that this patient has abdominal pain, and because you know that there's an association with Henoch-Schönlein purpura and intussusception, you need to check your stool for occult blood. Remember, we talked about intussusception, and we said that intussusception can cause sloughing of the intestinal mucosa, causing what we think or refer to as current jelly stool. The other things that you would be considering is to get a complete blood count and also a SED rate. So you do the guaiac of the stool, and it's positive. The SED rate is 18, which is within normal limits, and your WBC count, as well as your hematocrit and platelets, appear to be within normal limits. However, in addition, because this patient had abdominal pain, you ordered a urinalysis. And when you ordered the urinalysis, what you found was that the patient had 2+ protein with RBCs and WBC cast. Now you're going to say, wait a second, Dr. Kerner. RBC cast, that goes with a post-streptococcal glomerulonephritis. What are the examiners trying to do to us? How much can they trick us? Let's think about it for a minute. Henoch-Schönlein purpura can also have RBC cast in their urine. They can also have hematuria. The fact that this patient has a rash from the buttocks to the feet, the fact that he has a palpable purpura, the fact that he has abdominal pain with the hematuria can only really point to Henoch-Schönlein purpura. If the person had a post-strep glomerulonephritis, you would have to have either a history of a throat infection, right, with strep, group A beta hemolytic strep, or I see some of you in the audience telling me that he could also have had a skin lesion, impetigo, which we said earlier had a component of group A strep, which could give the patient a glomerulonephritis. So there are a couple things where we may see an association of red blood cell cast. Again, they don't make it particularly clear-cut. They give you enough evidence to lead you to the diagnosis, but not enough evidence that you don't have any other diagnosis to consider. In that case, it wouldn't be an exam. All right? And it wouldn't be true to real life. So this child, we said, has Henoch-Schönlein purpura. We talked about that earlier this morning when we talked about intussusception. And we said that the barium enema is both therapeutic and diagnostic for most cases of intussusception, and that you would do a barium enema. Or somebody had asked me during the break, could we do an air enema? And the answer is yes. So you could do either. But in this particular case, the Henoch-Schönlein purpura, we are thinking of the vasculitis as a lead point. Therefore, a better approach would be, if we were suspecting an acute abdomen with intussusception, is to give steroid. And that is oftentimes on your examination. All right? Now, what else do we need to be thinking about? Well, what can we do to help the patient who has Henoch-Schönlein purpura get better? The first thing is supportive care. Adequate hydration, bland diet, pain control if they have any with acetaminophen. In this particular patient, we have to admit, and the reason that we have to admit is not because of the hematuria, but because of the abdominal pain. And we want to make sure that that is relieved prior to discharging the patient out, so that if we needed to do a surgical intervention, that we could be observing and intervene prior to a poor outcome. What else do we need to be thinking about? Again, IV steroids, the hydration, and your renal function should be monitored. All right? Some parents may ask you, if they do have a component of hematuria, how many of the patients go on to chronic renal failure or chronic renal disease? And the answer is going to be it's very minimal. Other things that you need to be aware of is that if you have a Henoch-Schönlein purpura case, that most laboratory tests are going to be normal. However, your SED rate may be increased, and you might even have some anemia, especially if you've had the hematuria, and if you're losing blood in the stool. However, in the Henoch-Schönlein purpura, even though you have the bleeding, the coagulation studies are going to be normal. We've talked about the treatment, and we'll now go on and discuss other areas of differential that might have been considered using this case. All right? One of the things is Rocky Mountain spotted fever. We said with Rocky Mountain spotted fever that the rash starts usually on the extremities and works its way in. There's a triad for this illness. It's headache, fever. The patient is pale, and has pale rose-red macular papular rash. So anytime you see the word rosette, R-O-S-E-T-T-E, or pale rose-red macular papular rash, you need to be thinking about Rocky Mountain spotted fever, because that's the buzzword. That's the key to making that diagnosis. Again, they're going to have a severe headache. Usually, you want to go back and get a good history and a good physical. You can never be punished or points taken away from you because you're asking for more history or because you're asking for more of the physical. All right? So you want to do a complete history and physical. You may find that the patient has a tick exposure. You also might find that the patient not only has a rash, but the rash is on the palms and the soles. Now, we didn't mention, we were speaking about other rashes, but measles can also occur on your palms. All right? So you have very limited amount of rashes that can occur on the palms. But we said Coxsackie virus could also occur on the palms because that's hand, foot, and mouth disease. Okay? And the only other thing I can think of that we mentioned about palms was Kawasaki with that red, swollen hands. So you have 4 things that you should be thinking about when you are looking at palm rash or palm coloration or palm swelling. Now, what other things are we thinking about here with the Rocky Mountain spotted fever? First of all, you would want to confirm it. And how you would do that is through serology. And it's usually an immunofluorescence antibody assay. Now, a question came up during the break because if you look at the notes, you'll see that in the notes it says that for leptospirosis, we're going to use either penicillin, or if you were allergic to penicillin, we were going to use tetracycline. Now you're seeing again that the treatment of choice for the Rocky Mountain spotted fever is tetracycline or doxycycline. And many of you are good physicians because you came to me and said, listen, can you say this? I thought you're not supposed to give tetracycline or doxycycline to a young child because doesn't that cause problems with the teeth? Doesn't it make the teeth yellow? Doesn't it cause other problems with the skin when they're exposed to sun and with the bones? And the answer is, does the risk outweigh the benefit? All right? For leptospirosis, the benefit is it would be better. If you're allergic to penicillin, the next treatment would be the tetracycline. Rocky Mountain spotted fever for years was treated with tetracycline as the number one choice, and it still is, tetracycline or doxycycline. However, in children less than 8 years of age, we used to use chloramphenicol. Looking at the outcomes, what we found was that children, no matter what age they are, do better with tetracycline or doxycycline because it's the drug of choice for Rocky Mountain spotted fever. Therefore, if I'm a small child, I, in this case, can receive tetracycline because the benefit outweighs the risk of getting yellow teeth. And how do I know that? Why is that okay? It's okay because you're only going to use the tetracycline for a short time. If you looked at another disease like Lyme disease, which is also caused by a tick, the drug of choice for that is also tetracycline. However, because you have to give it for 2 weeks and in some stages a month, they say don't use it. What they say to use as an alternative is a penicillin. Okay? So it's just some few exceptions to the rules. And we're not trying to confuse you. But again, the idea of being a licensed physician is first, do no harm. So some of these are important points that you need to glean because if you are out in practice, you want to make sure that you make the best choice for your patient. All right. Remember that a delay in treatment of Rocky Mountain spotted fever would cause death. Kawasaki disease, we actually have spoken about. And the other problem that we want to talk about is Neisseria meningitidis. Okay? As far as Neisseria meningitidis, this also can start as a rash that's on the ankles. And it can spread upwards. Remember that for Neisseria meningitidis, you can be lethargic. It can cause meningitis. The clinical symptoms in an older patient are photophobia, intense headache, vomiting, lethargy. Remember that they can also have purpura and petechiae. The other thing that you need to think about for Neisseria meningitis or Neisseria meningitidis would be that there is a definitive diagnosis that would be made by lumbar puncture. That's how you're going to make the definitive diagnosis. However, if the patient is too ill to receive the antibiotic therapy, then you would just immediately treat with ceftriaxone. Let's talk about systemic juvenile rheumatoid arthritis. This also may mimic, because of the rash, the patient who may have Henoch-Schönlein purpura. You might want to consider it, all right? Because sometimes in Henoch-Schönlein purpura, the patient will get joint pain. And so this should be in your differential diagnosis. You want to make sure that you do look for a rash, and the rash buzzword would be that it's salmon pink in color, or they may use the word evanescent. Right? These patients, though, might have more of a joint manifestation, and it usually occurs over a longer period of time. It wouldn't be a sudden diagnosis that you make. Okay, the patient would have been ill probably for a longer period of time. For systemic juvenile rheumatoid arthritis, remember that the goal of therapy for you as physicians should be to preserve always the joint function and to approximate normal lifestyle. The other thing that we want to make sure that you do as first-line therapy is non-steroidals to alleviate any pain. And this would conclude our case of Henoch-Schönlein purpura with the case review and the differential diagnoses. And it will bring us to the next chief complaint, which is, my skin is breaking out.